Consumer Tax Chair,
This meeting is being recorded.
also the Director of Kentucky Voices for Health. So welcome to our Consumer Tax meeting, and thank you all for joining us today. We'll go around and quickly introduce our TAC members. So at this point, if everyone can make sure to have your video on, that would be helpful. We need that for a quorum. So Arthur, Miranda, Christine, and Rosie, if you want to just introduce yourself and your organization or the group that you're representing.
I'm Rosie Stafford. I'm with the Family Resource Youth Service Center Coalition of Kentucky. I'm a coordinator in Ashland for Family Resource Center, and I serve 3 elementary schools and have a daycare in my building.
Arthur, you want to go next? It looks like you might be muted if you're talking. Could be that he's talking to his assistant. Miranda, why don't you go next, and then Christine?
Sure. I'm Miranda Brown. I work at the Kentucky Equal Justice Center. I coordinate our outreach. I'm a connector, so I help people sign up for Medicaid and connect coverage.
Hi, everyone. I'm Christine Jackson, and I represent AARP as one of their lead volunteers. I've been working in Lexington for over 5 years now with the team there in Lexington, so I'm happy to learn from you all, this whole system.
Arthur Campbell. I'm representing PNA today.
Yeah. Thanks, Arthur. And has Patty joined us yet?
No.
Okay, I don't think I see her here, so we'll keep going. The next item on the agenda is approval of November minutes, and I think that I may have gotten that wrong. We don't have November minutes, we have December minutes. Am I right?
Yes, you're right.
Yeah. All right, sorry about that, everyone. But if I could get a motion to approve the December minutes and then a second.
I motion to approve the December minutes.
I'll second it.
Thank you, Christine. All in favor, say aye.
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 Aye. Any opposed?
Aye.
Okay, motion carries. Thank you. And then we will start with, well, actually, before we just go through the agenda as the order that we have it here, are there any folks from Medicaid here who need us to go in a different order? Okay, so we can change things as we go, but we'll start right now with old business and that first item, which is the issues that have been reported by connectors and anything that's been done since our last meeting, which was in December, to address some of those issues.
This is Lee Geis. I think that we address those issues as we step through them. And I'm hoping that any actual bugs were fixed as we went through. So I haven't heard anything for a little while. So I hope that everything was actually taken care of.
I know that many of the issues that were reported to the KHBE and Deloitte were addressed, as if they were system errors. But there were those issues with name changes and a few other things that I think Miranda may have reported, especially related to some of the cases for immigrants that she's been supporting. Miranda, have those things been resolved?
I'm not sure about name changes. That's not an issue that I've seen specifically, but what I
Those
have
were ones that Miranda, or excuse me, Priscilla and Kara and a few other connectors have reported.
An issue that I have continued to see is sometimes, now, last week, this didn't happen on a case, but it has happened recently, which was emergency Medicaid cases will not show results at the end. It will say your case is pending a 30-day review. And if we call DCBS, they say they don't see an application. So it doesn't appear to have processed.
Oh, that's news to me, so I don't know. Have you sent, did you tell DCBS when you called them
Yes,
that it doesn't appear to have processed?
yes.
Did they say anything about reporting it to the help desk?
Well, I'll have to pull up my notes to see exactly what was said. But I
Because
believe.
that would certainly be a technical issue.
Mhm. Right, I think usually they just say, we'll just resubmit the application, and I'm like, well, what if the same thing happens? And sometimes they have done it over the phone with us at that point, but it is an issue that if the system says it's processing a case, that it's actually not processing at all.
Well, yes, it is a technical issue, and working around it with DCBS, I guess we need to remind them that using a workaround, yes, is good to get coverage, but we also need to have that information sent forward so that we can research and try to find what the issue is.
Yeah.
Next time that happens, Miranda, if you could take a screenshot and send it to me, that'd be great.
Okay, thank you, Lee.
Sure.
So Lee, I know that Kara and Priscilla have sent you some issues with the name changes.
Right.
And they were being overwritten, like somebody would update their information and then it would go back to the old, spelling or an old name. Is that something you've been able to look into?
We send those, let me explain how that works, okay, and why it works the way it does. In order to make sure that we have one person with, one Lee Geis in the system, whether or not I spell my name Lee A. Geis or just Lee Geis, or somebody misspelled it with an S instead of a C. We have what's called the Master Client Index. And when there's been an issue or when somebody has reported a change to their name and it hasn't been verified, like we have a social security number card on file that has my name as Lee Ann Geis, and I call DCBS or I ask for my name to be changed to Lee Geis, but I don't ever send anything. The Master Client Index is not going to allow that change to be made.
Right. Unless you have updated verification, right?
Unless you've updated the verification.
So I think these are cases in which updated verification was provided.
Well, then it shouldn't have happened.
I agree with you.
I tell you, when they send me information like that, I send it forward to the help desk to see if they can determine what has caused something to be overwritten, because it shouldn't be overwritten unless the circumstances I described have occurred. So I'm hoping that all of those have been addressed, unless I have some of those emails still sitting in my inbox waiting for me to get to them.
I'll check with Priscilla and Kara and see if they can just resend it to you or look at the status. They can probably look up those clients in the system to see if something's changed.
Okay, great.
Yeah, these were unusual cases, not the typical. So the next item is our question What updates are there on the development and the dissemination of a document explaining the difference between presumptive eligibility and emergency time limited Medicaid?
Still under review.
Okay. Do you have an idea of when it'll be available for us to take a look at?
I do not. Probably 2 days after a couple of other people are cloned in Medicaid. I'm sorry, I don't know right now.
Yeah, no, I know things have been very busy. Okay. Well, any updates you can share would be great. And if it's possible for us to review a draft just to get some feedback to you, we can keep it, confidential amongst just the members of the TAC. The next question here is the status of a diagram that I think you've been drafting, Lee, related to Medicaid and K-CHIP eligibility.
Yes, and I do have something to explain that to give you a deadline, sort of. We were working on the sample that you gave us, which was fine until I was given another task to redo a chart from another state to put in our annual report, and that is a much better, in fact, chart. And I have wisely delegated that responsibility to someone else and given them a deadline. So we should have that to review by the early next week.
Okay.
I should get it by the end of this week, and then I'll do just a cursory review and let a couple of people inside the cabinet take a look at it. And then we'll send it to you all to see if it meets your standards.
Okay, yeah, that sounds great. Thank you. And then the Medicaid K-CHIP enrollment reports that are going to be on the statistics page. I actually didn't check before this meeting if that had already been added.
I've asked for them to be added. I have not checked to see if they've been added, but I have asked for them to be.
Okay, and they'll be updated monthly now.
Yes.
Okay, fantastic. Thank you. The next question is the status of amending the state plan to lift the 5-year bar on covering legally residing pregnant women.
I don't, what I don't know is has that decision been made by leadership is what I'm unaware of. And so Veronica was in a meeting and couldn't be here for a little while. If she gets on if she is able to join the call, can you just go back to that?
Yeah, we can do that. The next one is what DMS is doing to ensure network adequacy. This was something else that may be a Veronica question, I'm not sure, to ensure that these network adequacy requirements are being met. And more specifically, what an enrollee can do if their MCO is not meeting those standards.
This is Angie Parker with Medicaid. I can answer. I'll start with the first question. What is DMS doing to ensure network adequacy requirements are met? Each MCO submits a report on a quarterly basis that is reviewed by DMS personnel. As we know, there are challenges sometimes with certain areas for MCOs to acquire contracts, and even if they have a contract for those Medicaid providers to see Medicaid enrollees. So those do occur from time to time. We also review complaints if that comes to our attention. And what can an enrollee do if their MCO is not meeting those standards? If an enrollee has a specific physician they need to see, there are 30-mile rules for your primary care and hospitals. And there are 50-mile rules for other specialists. So if MCO A, the enrollee wants to see Dr. Smith, MCOA in which the enrollee is enrolled does not have MCOA, but they do have a provider Dr. Jones, who does the same type of services within their network, within the same period of time or miles, they may request that they see that provider who is in their network. Obviously, if they supply the same services, then it's a possibility they may ask that enrollee to go to a different provider. If they do not have that provider in their network or within a reasonable time or miles, the MCO is to work with that enrollee to find the services in which they need or require. If it comes down to they want to switch because they don't want to see Dr. Jones or Dr. Smith, then they can apply for a disenrollment for cause with the MCO. And the MCO will either work with that member or try to get a contract with that provider in order to provide the services in which an enrollee needs. I can't give you it's X or Y, or because there's a lot of different variables that could come into play here in which network adequacy is evaluated for that particular enrollee.
Yeah, no, I know it's somewhat complicated. What I hear is that when someone calls in, to the member services line for an MCO, they can be given, there's a provider directory, of course, and they can be directed to any of the providers that would be within those distance standards. Now, the time standards are obviously not as clear because you don't get that information unless you make the call. And so then the enrollee can be, kind of tasked with having to make calls to 10 or more providers to see if they have an appointment available. And then, that often results in being told that they're not taking new patients or that they're not even participating with that MCO, or, they may or may not have an appointment available within those time standards. But I don't know that the enrollee is being told on the phone, make these calls if there is no provider available within this time frame, call back and we will approve someone out of network. I feel like that's the piece that's where the breakdown is. And it puts all the onus on the enrollee to do all of this legwork to determine if there's a provider that, is available within a reasonable amount of time.
Well, I mean, as you said, there is a provider network that it does address certain specialties, but I would suggest if they're having issues with the customer service or member services with the MCO, that they say, well, I have contacted X, Y, and Z, and I have not been able to. They should be able to provide assistance in determining who they can see.
Are the MCOs required to tell someone up front, if you cannot find a provider within these time standards or these distance standards, we will then approve someone out of network?
Are they required to?
Right, that's my question.
Tell them. They have to find, services for the enrollee. So if it's something that they need, if it's primary care, or if it's a gallbladder surgeon or a surgeon, a general surgeon, they should be able to assist that member if they're having challenges in locating that particular provider.
Yeah, yes. I guess I feel from what I've heard that they're not necessarily upfront with what they're required to do and, what the enrollee needs to do in order to get an out-of-network provider at the end of the day. It's, it can be one of those things where it's a lot of back and forth and a lot of work being done on the enrollee's part to find a provider. I think it would be helpful if upfront the person on the call, center line said, this is what we're required to provide. If you can't find a provider that meets those standards, then we will. I think giving somebody that information up front would be helpful because not everyone knows the rules. I would guess that the majority of people don't know.
Well, I mean, an MCO can only make really recommendations. So they have a provider network and they have all these providers in this area. And that member services say, well, we have doctors XYZ and ABC in your area. And yes, they cannot specifically recommend somebody because they all are the same specialty. They're all primary care. So it is an individual choice of those network providers who that member wants to see or can see. So like I was kind of explaining earlier, there is all these providers. There's A and B, doctors A and B in this area, but the enrollee prefers A, even though they provide the same type of service, but that A is not in their network. They could still go to B, who is in their network.
Right, right. No, I understand the issue of preference, and that's not really what I'm talking about right now. Just access to a particular type of service that meets those standards. But I guess maybe this could be a recommendation that we make that MCOs be required to, disclose up front that if there is not a provider available within the time or distance standards, that the enrollee can then call back and get an out-of-network provider approved. I feel like that's the only way that people will know that that's a process that they can go through and something that they can request, because most of the time, if you're told no, you just assume that something's not available and you kind of give up.
Well, if that, I would always love to hear when those challenges are happening.
Well, we know they're happening because whenever, the seeker shopper surveys that are being done are finding that, more times than not, whenever a provider is called who's a Medicaid participating provider, they're not available within those time standards. So we know that they're happening.
Right. And I'm not, and I don't want to debate that with you because I know we both talked about that before. And I understand where you're coming from in that. And it's twofold, as we've talked about. They may be contracted with the MCO, but they may they have openings, but they allow other insurers first into their, a lot of that is in what the provider chooses to do. Is that right? No, it's not. And I mean, if that is occurring, that would be something that the MCOs or DMS would have to or address. But to your point, and that people give up because they can't get in, then yes, the MCO should be assisting with access to care. Now, there is disenrollment for cause, which I've talked about, and there is information on the website on that. And it's also addressed in the member handbook. And a lot of that information on access to care and their member services information should all be in the member handbook.
Yes, there is information. It is different from one handbook to the next. And one thing that we had actually recommended on our last call or our last consumer TAC meeting, a recommendation that we made to the MAC, and I believe the MAC approved, they didn't have a quorum. So it may not have come through yet, but was to create a one-pager that could explain more consistently, what those steps would be for an enrollee to go through. And, if something is not available, what they can do to either, get the out-of-network provider approved, or if that's not happening, if the MCO is not agreeing to it for whatever reason, what they can do to submit a complaint. So I think that that process just needs to be more clearly sort of defined for enrollees. And that's a recommendation that we've already made. So,
okay.
One other thing I wanted to clarify with you, you had said that you also review complaints when they come to your attention. How do those complaints come to your attention? Like what kind of, are they from the enrollee, and how would they be able to submit that?
Well, enrollees there is a website, web address. I believe it's DMS shares. I'll have to get that specific, but to make sure that you have that in the minutes, that we get them from there, that they go to Charlie and she reviews them and she'll send them to us if there's an MCO complaint. It can come from constituents. It can come from our member services line that in order to address those types of complaints. MCOs are to keep track of grievances and appeals. And when they get those grievances, and those are to be in their reporting, which they submit to us on a monthly basis. And they are, that is also something that they are to resolve a grievance within 30 days.
So all grievances and appeals get submitted to DMS for your review as well. Is that right?
Well, they don't get to, the MCOs report them to us when they have grievances. The number of grievances, yes.
Just the number, but not
And the type of grievance.
okay.
Angie, I may have missed it, but did you say the time frame in which somebody's supposed to be able to get a primary care provider within so many days or weeks, and specialist appointments? How long the provider has to provide an appointment before the MCO should help them find a different provider?
Yes, there are specific timeframes, and I believe it's 30, and I don't know. I would have to I don't want to misspeak, but I believe if it's not emergent, it's, just your annual exam, it's 30 days to see a doctor. If it's emergent, if it's urgent, within 48 hours. It could be 24. I have it here. I could find that specific information for you.
Yeah, I was gonna say, I can pull it up too, because I put it in some notes a few months ago.
Is there somewhere that I can find that? Is it?
It's in
That's
the
the
MCO
thing,
contract.
Miranda. That's where I find it very difficult to get that information and for it to be presented in a consistent manner between MCO or, from one MCO to the next. It's in regulation, and I do believe it's in the handbooks, but the amount of details and then what process you can follow in order to, get an out-of-network provider approved, I think that's where it kind of varies significantly, and people don't have that much information. I'm sorry, were you saying something else, Angie?
No.
Okay.
I'm trying to find the specific language regarding
Thanks.
when to see a doctor. I just saw it not too long ago.
I'm trying to pull up the notes and it's taking me a minute. So the time and distance standards right now are for primary care within 30 miles or 30 minutes from an enrollee's residence in an urban area, 45 miles or 45 minutes in a non-urban area. And then there are also standards in terms of, how many days. And let me see, appointment availability is
within 30 days for routine care or 48 hours for urgent care. Emergent and behavioral health within 24 hours a day, 7 days a week. Urgent care by any provider in the network shall be available and accessible within 48 hours of request. Immediate treatment for emergency room or behavioral health by a health provider that is most suitable for the type of injury, illness, or condition, regardless of whether the facility is in their network or not. So as I was saying earlier, it's within 24 hours for emergency, 48 hours for urgent care, and 30 days for routine.
Thank you.
Mm-hmm.
Well, Angie, I appreciate the additional information. And, if we do get any specific reports that we can share with you, we will. But I think generally, having something simple that we can share with enrollees would be really helpful. And just knowing that, if we're seeing this chronically, where, with the secret shopper surveys, providers are not meeting those standards, I think we need to see not just a case-by-case basis, sort of addressing it, but more providers that are being contracted. And we know that there are lots of challenges with that, but one certainly is probably what the payment rates are, or other, sort of more administrative issues that providers experience in working with the MCOs. And that really is the responsibility of MCOs ultimately. So the case-by-case basis is, one way to work on these issues, but if it is a chronic problem and we see that trend continuing, I think that there's more to be done on the contracting side of things.
Well, I would say if you hear specific MCO complaints on what you all are doing, to please bring to my attention.
Yeah.
If it's just onesie twosies, like, you know, if you hear anecdotal information from, it's kind of challenging to address those. But I agree when you're talking about the secret shopper, but they're also to address those when we get those reports and to evaluate that with the provider.
And then, you know, the request that we made, or the recommendation that we made at our last meeting, if that's something that we could work with you on to do that, you know, one pager, that would be fantastic. So we can follow up, you know, with that separately. And then our last question here is the status of the health disparity and equity TAC.
That's a Veronica question.
Okay.
Unless Angie, unless you have something to add on that one.
I just know that they're waiting on one more application, and then they plan on sending it to the governor once they get that.
Okay, thank you. I did hear something about that. I just forgot what the response was. Thank you, Angie.
Mm-hmm.
All right. Thanks for that update. Anything else before we move on to the next section? Medicaid enrollment and recertification. Okay. So our first question here is how many Kentuckians are currently covered under the traditional and expanded Medicaid, and how many are covered under presumptive eligibility?
So we have 1.66 million total members, 1,600 members in PE. Your other questions in B and in C, I have made a data request to see if I can, not to see if I can, on B to get that information, and on C to see if we can get that information.
Okay.
I don't know. That would be one of the challenges of getting the agenda late, is that we really don't even have a prayer of being prepared. On D, as far as the timeline for incorporating emergency time limit in Medicaid is in Connect is has been designed and is ready to go, but not until we are able to unwind. We made the determination that we are keeping everyone eligible right now. So I know it might be a little bit easier. And if you have somebody that you are having trouble getting emergency Medicaid approved for, just let me know. We will work to make that happen. But right now, technically, it would be almost impossible to change our eligibility over completely for one category of member when we have so many fixes in to maintain the maintenance of effort requirement.
So you're seeing this as an eligibility change or just a big system change? Did I hear you wrong?
It is an eligibility change. It's an eligibility system change.
Okay. The eligibility criteria remains the same, but it's part of the eligibility system. Is that what I'm understanding?
No, sorry. That might be what you're understanding, Emily, but that's not what I meant.
Okay.
I thought, no, that's not the right answer, Lee. What I'm trying to say is CMS, and I know that we've talked about this before, CMS contacted us and let us know that we have implemented emergency time time limited Medicaid incorrectly. And so we are going to be correcting that implementation. And that's what I'm talking about.
Okay. Yeah, I understood that part. I just, when you said eligibility, it meant something different to me, but this is helpful. Thank you.
When it says application and approval and connect, that means eligibility to me. So that's what I was talking about.
Okay. Yeah, I think for us, we're looking at people being able to apply through Connect in advance of having an emergency, just and be approved only in the case that they would then in the future have an emergency that would sort of trigger the coverage to start.
Correct. Right. So what CMS explained to us is that we are supposed to allow everyone who is technically and financially eligible for Medicaid, except for their immigration status, to apply without having an emergency medical situation. But we only pay for that emergency medical situation. So that is a big systems change in our eligibility engine.
And so you are planning right now to do the unwinding of that maintenance of effort, which has kept people covered, enrolled in Medicaid during the pandemic first, and then do the system change for emergency Medicaid.
Pretty much, maybe not right together, but closely, close in time.
Okay, thanks. Miranda, do you have any follow-up questions? I know that's something that you've been, okay. Then the last question here is, how can MCOs, providers, and community partners work with DMS to educate Kentuckians about the MOE unwinding and the redetermination process and timeline?
So we have some facilitation assistance now to put together a communication strategy plan, and we'll be asking for folks from the community as well as our MCO partners to come to the table and help create that plan and work with us on it. And that is where we are. You know, I put both yours and Miranda's name down, but certainly either one, you know, if anybody else on the TAC is interested in joining the meetings, send Erin or send an email to wherever Erin is taking her emails up through, and I will put you on the list.
Okay, thank you. Are you still anticipating that, like, I think the number that you gave us last time for the number of people who would have to actively recertify would be less than 200,000? Is that still what you're thinking?
No, the number, that 200,000, less than 200,000 would be the number of people that will likely be terminated from Medicaid.
Who would no longer be eligible.
Correct.
So how many do you expect to actively recertify versus passive renewal?
Well, we generally have about 75% success with our passive renewal. Not everybody can go into passive renewal, however. And I don't know that breakdown. I tell you, the folks, the non-Magi folks have less of a chance of getting into the passive renewal pipeline than the Magi methodology, because some resources change in value as time goes by, and they cannot be passively renewed. Or incomes that go up and down can't be passively renewed. So they're only, and I don't know what that, I used to know what the percentages would be, but I just don't know right now. So if you want to know that, say so in a question, make sure it's on the agenda and I can find that out for you next time.
And ask for the breakdown between Magi and non-Magi.
Sure.
Okay,
Uh-huh.
and just for the benefit of our other TAC members, Magi stands for Modified Adjusted Gross Income, which was a change that I believe was part of the Affordable Care Act. Is that right, Lee?
Yes.
And so it's a different way of looking at your income and doesn't include assets, whereas non-Magi includes some assets. Is that right?
At a very high level. Right.
I'm
So
trying to make
yes.
it really simple.
Yeah. The Magi methodology looks at your taxable income only. And non-Magi is where income and different kinds of income and certain levels of resources are also part of the calculation. So that's what you said.
And typically, the majority of Medicaid enrollees are going through the Magi process now. Is that
Yes.
also correct to say?
Yes. Most of the non-Magi enrollees will be long-term care supports and services. So nursing facilities, ICF, IDDs, wait, that's coming, waiver, 1915 Sea Waivers.
Mhm. Thank you. It's just lots of details and nuances in all of these programs, so I appreciate that. Any other questions related to enrollment and recertification that people have?
Emily,
Yeah,
is this a good time for me to share?
yes, I think it is.
Okay, yeah, because a lot of what you all were saying, I've dealt with. So just so you all know, I actually was on Medicaid before I even was asked to be on this board, which is, so I'm kind of like a very perfect example of somebody going through a lot of what you all are saying from the user end. So I had a situation with COVID and a combination of caring for our 90-year-old in-laws mom with dementia. My husband went back in 2020 unemployed. So, and then I had a medical condition and with no insurance. So found out I could get Medicaid, got it. Then last year, when husband became gainfully employed, reported the income and was told that we still qualified, which was, I was surprised, but you know, I'm not going to complain. Sure, yeah, that'd be good. So because he does contract work, he doesn't get insurance very easily. So when I wasn't sure about that, and so I got a connector to help because I couldn't really understand how that worked. And she got me on the phone with, I guess it would be DMS or DCBS. And it was verified with somebody on the other side because she wasn't sure about it. And so time went on and, you know, he jumped a couple jobs because he does contract work. And then it turned out he got another income increase that we called again and found out that, you know, we're over that. And so we had to pick a qualified health plan. So I tried to do it on my own and I could not understand it. And, you know, I have a college degree and I ran a business for 16 years and I couldn't figure it out. So I called the connector back to help me with that. And the end of last year, you know, we got the notices that our Medicaid was going to run out the end of January. So we did still report the increase in income. And we also, so then we got told that we get this tax, what's it called again? The tax credit. I forgot the name of it. The word for, you know, you get a tax allowance.
Yes, it's advanced premium tax credit.
That's right. And it showed it up and we thought, okay, good. And then my husband, I said, you better check with your contractor. Can they cover insurance or not? Because Medicaid's going to run out. And he had one day to figure it out. For him, it was going to be $500. To add me was going to be $1,600 a month. So when we reported, our connector asked us to report all of that, the offer and everything. And when we did, the tax credit disappeared. And so then we thought, oh, shoot, because the range, looking at all the healthcare plans available through the QHP range starts at around 6 or 7 and then goes on up, right, depending on your bronze, silver, and gold. So then I was like, shoot, it's still going to cost us a lot of money. So then like I talked to Emily about it, and she had Priscilla, one of the connectors in her office, help me a little bit. And during that time, I went back into the website, and then the tax credit was back there again. So I went ahead and signed up for it, but I wanted to sign up for it so that it would become effective February 1st. But we had all this technical issues going on. I didn't get to sign up for it till January, the end of January. So apparently the coverage is not effective until March 1st. Right? Because if you waited from the 15th to the 30th. But Priscilla told me, and she showed me the document for natural disaster and technical issues special enrollment, but we couldn't figure out how to do it in time. And so she's supposed to be checking on it. I still haven't heard whether it could be retroactive so that it becomes effective, because there was so much technicalities. So to summarize it all, it was very difficult to go through, and I still don't really know. I know that I believe I have coverage through QHP, although I haven't seen any paperwork from anybody or an email. I think it's online. And then I don't even know, do I have insurance coverage right now or not? Or, through QHP? I know the Medicaid expired in January because of all those changes that we reported in income.
Christine?
Yes.
A few minutes ago, I talked about the maintenance of effort requirements.
Yes.
And the maintenance of effort requirement means this: if you have Medicaid during the emergency, during the public health emergency, we could not terminate you.
Right.
Period.
So Lee, that's what I actually told Christine when she called me. And I said, this must be a mistake. But Christine, you got a letter that said you were terminated.
Yeah, it wasn't a letter. You know how on the site it'll tell you,
yes,
something that tells you all that's going on, and it did. It gave at first it said that we weren't expiring till February, the end of February, so we kind of didn't worry about it. But when when I got on with the connector and somebody that we called into, they just took all the information, and then it came out on paperwork on the website saying that we requested to get out of Medicaid, but we did not. We just reported. We just reported what we were supposed to do. Whenever your income changes, you're supposed to update and report it. And that's what we did. But the verbiage made it sound like we asked to get off of it. But,
Well, that's the only reason, right? That is the only reason that we could terminate you, is if you moved out of state, you passed away, or you requested it. Now, if you applied for a QHP and advanced premium tax credits, you would not be eligible for that unless you terminated your Medicaid. You can't get both benefits at the same time. So
right.
I don't know why your connector did not understand that. I don't know why you got a letter saying that. Well, I do know that some people did get a letter saying that because they had reported their incomes. And when we switched our system back to the state-based marketplace, some notices went out indicating that your Medicaid was going to end at a certain date, and QHP you would be eligible for a qualified health plan. But that's not true. We try to post it and train everybody to understand that that was not true. It was just not true. So
and
I am very sorry. If you want to privately send me your birth date and the last 4 of your social, I'd be happy to look it up for you and see if you're still eligible for Medicaid, because you might not be, but you should be if you didn't ask to be removed.
Okay, great. I appreciate it. Yeah, no, we just we were just reporting the income change. We, you know, who wants to pay for, you know, hundreds of dollars a month if they don't have to, especially when you're digging yourself out of a hole, you know? So, yeah, I'll do that. So birth date and, did you say social?
The last four of your social would be
Okay.
helpful so
Okay.
that I can make sure I have the right person.
Great.
So Lee, I know the letter that you're talking about that went out, right? You know,
Right.
before open enrollment. That's not the same as what Christine received, but I appreciate you looking into it for her. And of course, we're concerned that maybe other people have been terminated for reasons that don't fall into those, you know, death or moved out of state or requested. So wanted to, you know, share this one with you so that if there was a system issue or maybe just a training issue, that it could be addressed.
Yeah, and also, so that's the Medicaid side of it. So once we thought, well, okay, well, we don't have Medicaid, even the getting the qualified health plan, you know, we did get a document saying that we had the tax credit, and then we got a document showing we don't, and then we got a document again saying we do. So that whole was kind of stressful, and it was stressful enough that I gladly sought the help of a second connector, and, you know, and I don't even know when the qualified health plan goes into effect, but I appreciate if we can get that all resolved and smooth over. And I guess I'm the little guinea pig here.
That I am sorry you had all that trouble.
Oh yeah, you know, but
yeah.
It is, I told Emily's like, wow, I guess I was supposed to be on the board.
Perfect timing. It is complicated, but it only should be complicated for us. It should not be complicated for anybody who needs services. So my deepest apologies for that.
Thank you.
I was just gonna add, so there's kind of like two issues with Christine's situation. It sounds like two main issues at least. And one of them being the, that their notice said they requested withdrawal when they didn't. And I had a case like that in November or December, and that case has since been fixed, but it was a long process to get it fixed. And if it would be helpful, I could send you the case number so you could look into the history of it. And then the other situation with the APTC going up and down without the applicant having put in any additional changes, that has happened in several of my cases as well. And I've been reporting them through the issue tracker as time has gone on, but I have wondered as to, are these cases being fixed on an individual basis, or is the bigger problem, is that also being fixed?
Yeah. Miranda, I think sharing those would be helpful. And because I think you're right, the issue tracker is great to resolve an individual case, but it's unclear if a system issue is being fixed that way.
Generally speaking, if there's a trend that can be seen by the production technical folks, they would much prefer to fix the system once and not have to continually fix individual cases. So I can assure you that that is happening, you know, at a really high level. Now, whether or not what you're talking about with APTC, I just don't know. I haven't heard anything about that at all.
Do any other TAC members have questions related to enrollment, recertification, just issues with coverage more generally? Okay. Well, we can move on to the next section, which is the 1915 Sea Waivers. And transportation is something that we've discussed, you know, in these meetings before. It's obviously a major barrier. And I know that Pam You were working on something, and Arthur, you also had something that you wanted to share related to transportation. What order would make the most sense? Who wants to talk first?
This is Leslie. I'm making sure that Pam's back on. She was having some difficulty. Just a second.
Okay, thank you.
Oh, she wants to know if you have a dial-in number. She's having trouble getting back in and hearing. Let's see. Is there a dial-in at the top of the agenda? I can't see the top from here.
Not, I just,
Okay.
I always link to the TAC page because that's where
Yeah.
information is
I-
posted.
Yeah.
Um,
Yeah.
Miss Pam.
Yeah.
Ken
Oh,
can go
the
before
Dave.
before you do.
Yeah.
Oh, you said Miss Pam can go before you.
Yeah.
The TAC page lists this dial-in number for the meeting. I just put it. Oh, so did Emily.
Thanks, Miranda. Jinx.
Thank you.
And then, Arthur, do you want to wait until Pam is back on to share your comments?
Yeah.
Okay. Well, why don't we, while we're waiting on Pam, we can go down to the next section, since she's going to be the one to best answer anything about the waivers. So our new business, we have a question here. How can or how will Medicaid enrollees be able to access free over-the-counter COVID tests? Is there anyone on from DMS who can answer that question?
This is Angie. I'm looking to see if I can find an email on that, but Dr. Fatima Ali, our pharmacy director, would probably be the best person to be able to answer that.
Okay. Yeah, even if we could get the information, via email after this call, I think that'd be helpful. But our understanding is that Medicaid enrollees should be able to get free over-the-counter tests, but we just don't know exactly what that process looks like, what we can tell people.
Okay. I'm sorry, I had to take a call from the secretary's office, so I didn't hear this part of the conversation, and I apologize. They should be able to go to the pharmacy and get them over the counter, right, Dr. Tyria? Go ahead.
I think they can get up to 4 tests, and there's a standing order out there that any Medicaid member can go and get the test at the pharmacy.
Is there information that's been shared with Medicaid enrollees about that?
I don't know the answer to that.
If there is something, whether it's, a letter or.
It probably wouldn't have been a letter from us. It probably would have come from the MCOs.
MCO. Since we have MCO representatives on today, are you all aware for your own MCO if something has gone out to members related to over-the-counter tests?
This is Tabitha from WellCare. Let me just check with our pharmacy director. I'll get right back with you.
Thank you.
This is Angie with Medicaid. I found the email as far as DMS will cover all FDA approved home tests through the pharmacy benefit. This includes both prescription and OTC tests. DMS will place a limit of 8 tests per members per month. DMS will contain costs and incentivize the use of cost-effective options. We have a set effective date of 1/15/2022 for those changes. So this was on 1/20.
Thank you. Is that an email that was just internal, or is that?
Yes, it was just internal.
Well, we would love to share the information and really encourage people to use that benefit if there's information that you all have that we can, share on your behalf.
Let's see. Yes, MCOs are to send member communication. And DMS and MedImpact will be updating websites and asking MCOs to do so as well.
Great. And because this is a universal formulary or a single, it would all be the same process. It wouldn't be different from one MCO to the other.
It should be the same.
That's
The
great.
information would be the same, yes.
Okay.
As you know, MedImpact is the pharmacy benefit manager, but
Right. Yeah, that makes a big difference. I think that answered my question, although it would still, as I said, be good to get the information that we can share so that people are aware of the benefit and we can just be helpful and, kind of promoting it. Was there any other new business before we go back to the waivers? Okay. And does anyone know if Pam's been able to join?
I don't see her.
Yeah.
You'll read what you have.
Yeah.
Tell them you'll read what you have.
Yeah.
Okay. Are you ready?
Yeah.
Okay.
I am. I
Mhm.
I need to read what I am.
He asked if y'all wanted him to read what he have.
Yeah.
Arthur, I would like for you to read it. I just feel like Pam should be here to have that conversation.
Yeah, he said it, but if Ms. Smith is not in this meeting, then he suggests that we table this issue until Ms. Smith is with us.
She was here earlier, and I'm hoping that she can rejoin us. We may just need to give it a few minutes, because I know this was something we tabled from the last call.
He said, may he read what he have?
Anyone from DMS, can you give us an update on whether you think that Pam's going to be able to call in?
Checking on it.
Okay, I just spoke with Pam and she is trying to get reconnected right now. She's having a lot of internet problems.
Thank you for checking. We'll just give it a few minutes. We've covered everything but our recommendations. So I think that, and let me look at the time. We have plenty of time, so let's just give it a few minutes and see if Pam can join us. While we're waiting, we could do recommendations if people would like to go ahead and do that. There's one that I had brought up, when we were talking about network adequacy, which would be, I think this is how I would phrase it. When an MCO member contacts customer service regarding the availability of a provider, we recommend that the MCO representative be required to disclose the network adequacy rules that they are required to meet up front in order for the Medicaid member to understand the process for getting an out-of-network provider approved. Does that seem clear? Or is there another way we should phrase it?
Can you repeat it?
Yeah. When an MCO member contacts customer service regarding the availability of a provider, the consumer TAC, we recommend that the MCO representative be required to disclose the network adequacy rules they are required to meet up front in order for the Medicaid member to understand the process for getting an out-of-network provider approved.
That sounds good to me.
Okay. Anyone else have thoughts on that?
This is just the request, right?
Right. We make a recommendation to the MAC, to the Medicaid or Medical Assistance Advisory Council. And then if they accept that recommendation, then DMS is required to respond to it. It doesn't mean that they have to agree with it and also make that change. But that's the way that as an advisory council, the MAC operates. So they make those recommendations and then DMS will respond, with whether or not they will make a change or kind of explaining why a change can't be made, that sort of thing. Well, then I will ask for a motion to approve that recommendation and a second.
I motion to approve the recommendation.
Thanks, Miranda. Anyone second?
I can second it.
Thank you, Christine. All in favor say aye.
Aye.
Aye. Any opposed? Okay.
Mm.
That motion carries. So we will make that recommendation to the MAC at the March meeting. And then I wanted to ask if there are any other recommendations that people would like to put forward.
I think that in the past, we already made a recommendation about removing the 5-year waiting period for pregnant women, right?
I think that we did, Miranda. I can't remember what month we made that recommendation. But I don't think that there's any reason we couldn't do it again.
It might have been the month that we lost our meeting notes.
Right, that's possible. I actually feel like it might have been even before that. But I actually took my own notes from the November meeting, Christine, and now that I'm thinking about it, we didn't make any recommendations. We did make one recommendation in December, and we do have minutes for that. So luckily, we didn't have recommendations that got lost. But I couldn't, for the life of me, tell you what month we made the recommendation about.
I looked back in my notes and it was September of 2020 that we made a recommendation on removing the 5-year wait for pregnant people.
Do you have the response from DMS by any chance?
That I will also have to look for.
Yeah. Well, we'll look for that. And if Pam can't join us by then, Arthur,
I'm back.
at that point, it looks like Pam Smith is here.
Yeah, I'm here. I'm hoping that my connection is going to hold.
Well, then Pam, we will immediately go back to the 1915 Sea Waivers. Thanks for rejoining us. I'm sorry that you're having trouble. So Arthur,
so sorry.
No, it happens. Sometimes it's unavoidable. Arthur has something that he would like to read, and then we wanted to get any updates from you. So Arthur,
Okay.
why don't you go ahead?
He said,
Or
I want to apologize to Pam Smith and PNA for not doing what I said I was going to do. I was supposed to ask what people with disabilities would they needed in accessible public transportation across the state. Also, I was supposed to find out what each Medicaid waiver will and what it will not pay for in transportation, but I didn't do this. Pam and I was supposed to discuss this important need. But if Pam is not in this meeting, then I suggest that we table the issue until Ms. Pam is with us. Besides medical transportation, people out in the rurals are desperate for accessible transportation. If we need transportation like able-bodied people have, there is accessible transportation. We need out accessible. What do we need to take out? Oh, you said we need transportation like able-bodied people have. There's accessible transportation. It is so costly that we can't afford it, or it isn't any at all. and there are no accessible transportation across the county line,
Country.
we need to find out what each waiver will pay for.
Yeah. They you me say
Do you want me to
say
say it to you? Send it to you?
yeah.
Arthur, I think it would be helpful if you could send that to TAC members as well as Pam Smith. And then, did I understand you said you wanted to know what each waiver will cover regarding transportation?
Yeah.
Okay. So Pam, can you give us an update on where things are at with transportation for each of the waivers? Oh, did we lose you again? It looks like we did. Aaron, do you see her on here? Okay. Well, Arthur, why don't you go ahead and send that to the TAC members and to Pam Smith, and include Aaron, of course. And then we'll see what information she can share with us over email, but we'll have to put this, I think, on the next agenda, unfortunately, the April agenda. And is anyone else on here from DMS who can answer these other two questions about the HCBS spending plan? Okay. Well, it sounds like we may just have to hold all of those questions.
Yeah.
Thanks for putting that in the chat, Arthur.
I am sorry.
You say you sorry
Yeah.
that it is.
Worry.
That it is.
For
Poorly. Oh, poorly written out. You said that you're sorry that it was poorly written out.
Yeah.
All right. Well, I'm sorry that we can't cover this whole section, Arthur, but we will put it on the April agenda. And if we can get any information between now and then from Pam Smith or anyone else at DMS, that would be great. And then I see that Miranda, you put the recommendation or not the response to our recommendation in the chat. So thank you for pulling that up. And that it sounds like DMS said that they were going to conduct a fiscal impact study, and that I think we haven't seen or heard the results of that. So is anyone at DMS able to share?
This is Leslie. I think I've got Pam on now. Do you want to see if you can hear her? I think I've got her connected with two phones. Pam, do you want to see if you can speak?
Yeah, are you able to hear? Are you all able to hear me?
Yes, we can hear you, Pam.
All right.
Okay. So, Arthur, first, thank you for that. I was able to hear what you said. And so there's a couple of things that have happened that I want to share with you. Transportation I'm still working on what the final solution is going to look like. Our plan is to put a transportation standalone service in all the waivers as we do the rate study and we do waiver amendments. But in place of that, to address the need right now, I don't know if you had been able to see yet, but we sent out a communication and we moved the traditional attendant care service in HCB. We made it available as PDS. It's going to replace home and community supports. That includes the rate, so it will allow you to pay your attendants now up to $6 a unit instead of $2.88 a unit. That's effective on March 1st. We're going to start working. We're working with the FMAs right now to let them know exactly what they need to do to help individuals navigate that change and to do the modifications to the plan of care. But as part of that service, transportation can be provided. So to meet the immediate need, individuals can provide transportation under the attendant care service. Your service advisor would just need to make sure the plan of care captured that information. So whether that is, them taking you out into the community for a just socialization type event, or whether it be going to the doctor's office or going to the grocery store or to what other errands you would want that you would want to do. They just need to have address that on the plan of care. So more information will be coming out specifically to the service advisors so that they can help all the individuals to navigate that change.
He said, may he ask how much would that be an hour?
Yeah.
It's up to $24 an hour would be the maximum. It's the same as for a traditional provider. You have anywhere in that range up to the max of $24 that you could set as the rate for your.
If an aide was working for an agency, will that agency pay the aide? Pay how much would they pay? How much would they pay an hour? Will they pay the aide and how much an hour?
So the traditional agencies, Arthur, they kind of determine that. The service advisor, so is when you if you participant direct your services, that you have, there's certain taxes and things that come out. So the service advisors will help navigate that. I will say I'm not even the best person to answer the questions about that, but you will be able to determine what rate you want to pay, and you have that full. So you have the discretion that if there was somebody maybe that worked for you more or that did more for you, you can work with the service advisor and pay them a higher rate than maybe somebody that didn't work for you as much or maybe didn't do as much for you. But if you have questions, you have my email. Reach out to me and we'll walk you through it. Okay.
You have millions of questions. But we don't have time. Was that father?
Send me some, Arthur, if you send me some email of some times that you can talk, and we'll work on setting something up so that we can answer the other questions, okay?
Will that probably?
Pam, did you have any updates about the- Oh, I'm sorry, Arthur. I didn't mean to interrupt you.
Policy? Will that policy be what? Will the policy be sent out?
Yeah.
Yes, there'll be something, there's gonna be more information coming out in writing, yes.
Yep, Pam, you said that you had sent out, or Medicaid had sent out a communication. Did that go just to providers or to waiver participants? Who did that go to?
It had, the initial wave, I think, just went to providers, but we are, Kelly, our communications person was working on.
People may need to mute their lines if they're not talking. I'm not sure what that is.
Leslie, do you want to mute too? It looks like I got back in.
Oh. Okay.
Y'all hear me? No.
We can hear. Or we were hearing you. I don't hear you now.
Can you all hear me now?
Yes. We hear you. Well, we did.
Can you hear me?
I heard you for a split second. It may be, Pam, if you want to type. Sorry.
Can you hear me now?
Yes.
Okay, good. I think we were all kind of unmuting me at the same time, and we were muting and unmuting me at the and it went out high level to the PDS providers, but we are sending out, Kelly was working on the information to go out to the broader HCB population. And then I'm going to be meeting with the FMAs to walk them through what they need to do, because it's effective on March 1st. So we're working with the FMAs for them to help them be able to modify the plans of care and to understand exactly what they need to do and the conversations, the team meetings they need to have with the individuals.
Okay. Yeah, that's really helpful. Thank you. And a great change. So we appreciate you working on that.
It was well needed. So
there were two other questions here related to the HCBS spending plan, the timeline, and feedback that you've gotten. Do you have more information to share there?
I do. We actually yesterday afternoon received our full conditional approval from CMS on the spending plan. Now, everyone's is conditional because you're only approved as long as you meet the guidelines that they had set out, and you have to, we have to do reporting every quarter. So they also approved our first quarter of reporting that we did. So the rate study will be kicking off this month. So there's going to be a whole lot more information starting to be shared about that. Our communications work stream met, and we're going to develop a page just for the ARPA activities where there'll be more information, so it doesn't get caught, in a lot of the other communications. It's easier to see. I can share the initial feedback we had. The initial feedback we had from consumers and providers, but we're getting ready to ramp that back up, where we're going to start, now that we have more information to share, we're going to start having those meetings again. So I don't know. I mean, I can send that over. It was a lot of what we've talked about in general. So it may be more beneficial to wait until we start having those meetings, and give the providers and, members and advocates time to kind of hear where we're going specifically, and to kind of see what's going on.
Yeah, I think that makes sense if other people are okay with waiting for feedback once those sessions start again. So just to clarify, Pam, one, it's great that you finally got that conditional approval. I know it's been a long time coming.
I was a little nervous.
Was anything different from what you proposed?
No, they accepted all
Everything was
of our,
approved.
they did. And honestly, the questions that they had asked us in the request for additional information were more clarifying questions. It wasn't that they really had a problem with anything that we did or had a concern. It was just they wanted to be sure they understood exactly what the plan was. So yeah, and I we have a lot that we are looking forward to getting started. We've been having a lot of meetings in between, in January and so far in February with the planning and getting things up and going. And so we'll start engaging, people will start seeing more meetings and more engagement towards the end of this month and the beginning of March.
Okay, that sounds great. Arthur or any other TAC members, do you have additional questions for Pam about the 1915 Sea waivers or issues to share? Well, Pam, thank you for making all those efforts to get back on. We really appreciate it.
Thank you all for being so patient.
Miss Pam, I also got a question.
Yeah.
This is it is it for 4 or 5 years. 4 or 5 years. Is the policy for 5 years.
So
Is it
Arthur, that rate will remain in effect until the rate study is done. And as part of the enhanced FMAP, I can guarantee you that the rate will not go below that.
Okay, he said thank you.
You're welcome.
All right, well, thanks again, Pam. Arthur, I think this is good information to have. And if you have anything that you want to add to the April agenda for follow-up, just let me know. But it will be good to have that rate study kicking off now too. I think that will make a big difference. One other thing that we had just started talking about before Pam got back on was the September 2020 recommendation that the Consumer TAC made. And it sounds like the response from DMS was that they were planning on doing a fiscal impact study to look at, the fiscal impact of lifting that 5-year bar for legally residing pregnant women, and what that would cost to cover that additional population. So is there any information that you all can share with us today about that study?
This is Leslie. We may have to get back to you on that one.
Okay. All right. If you don't mind looking into that, Leslie, that would be great.
Yes, I'll make sure that gets followed up on.
I appreciate it. With that in mind, Miranda, do you want to go ahead and make any other recommendation, or wait until we have the results of that fiscal impact?
Good question. Does it make sense to just recommend a fiscal impact study?
And yes, I mean, I don't think it hurts if the response would be, well, we've already done one, or, oh, we never got around to it. So if you want to make that recommendation.
Okay.
So yeah, you tell me what you want it to say.
That we as a TAC recommend that DMS conduct a fiscal impact study to determine, I was just trying to see how to word it.
Just how about related to lifting?
Related to lifting
That's fine.
the 5-year bar for pregnant women who are considered legal permanent residents.
Okay, that sounds good. Do you want me to read it back?
Sure.
Okay. We recommend DMS conduct a fiscal impact study related to lifting the 5-year bar for pregnant women who are considered legal permanent residents.
I'm just wondering if we should word it more general. That's how it's stated in their response, but
I've always said legally residing pregnant women, but I don't know if that's semantics or not.
I wonder if we should just use the term qualified, pregnant women who are qualified
Immigrants.
otherwise qualified immigrants under Medicaid. Yeah, because there are other statuses that would be subject to this 5-year wait, but would be otherwise Medicaid eligible.
Who are considered otherwise qualified immigrants under Medicaid. Okay, I think that makes sense. And just again, for background for new TAC members, the Affordable Care Act gave states the option to lift this 5-year bar. So if you are an immigrant, typically even legally residing, well, yes, only legally residing, you have to wait 5 years from the time you come to the United States to be eligible to apply for Medicaid. So you could be eligible in every other way, but you just haven't lived in the US for 5 years, and therefore you can't enroll in Medicaid. Now, the Affordable Care Act gave states the option to lift that 5-year bar for children and for pregnant women. And Kentucky, back in 2014, I think it happened in 2014, lifted that for children, but didn't choose at the time to do that for pregnant women. And we're still advocating for that. So we know that when pregnant women get covered, of course, they have healthier pregnancies, healthier babies, and their babies are more likely to have coverage too. So that's kind of the background behind that one. So I will read it again and ask for a motion to approve in a second. We recommend DMS conduct a fiscal impact study related to lifting the 5-year bar for pregnant women who are considered otherwise qualified immigrants under Medicaid.
This is Leslie. I'm just double checking. You're going to send that through as a formal request, correct?
Yeah, that's right, Leslie. I mean, we still want to know if you've already done that. If you've already done it, of course, just having the results would be great, but we haven't gotten that, since we made this recommendation in September 2020. So we're just going to make this in the event that maybe it didn't actually get completed.
Okay, thank you.
Yeah.
So I can make a motion for that recommendation.
Thank you, Miranda. Second.
I'll second it.
Thanks, Christine. All in favor, say aye.
Aye.
Aye. And any opposed? All right, the motion carries. And do we have any other recommendations before we wrap up today? Any other items that people would like to discuss at our next meeting? Of course, I'll send out an email in advance, but if you have something on your mind now. I did get an email from someone who is a midwife. I'm trying to find the email. I'm not going to find it right now. And wanted to bring up an issue related to midwives and being able to provide those services and bill for them under Medicaid. And so I will be adding that to our April agenda, just so everyone knows. And if you have other thoughts for the agenda or other questions, in the meantime, just let me know. I will make note of those. The last item on our agenda is just a reminder about our meeting schedule. So you can see the dates for our upcoming TAC meetings. And then I believe I put those on our calendars this time. So hopefully that helps. And then there are the 2022 MAC meetings, which I'm required, or I attend those meetings so that I can report for the MAC for our TAC. No other TAC members are required to participate, but they're open meetings. You're welcome to join. And they're also now being streamed and shared on YouTube. So if you miss any of these meetings, whether it's a TAC meeting or a MAC meeting, you can watch those on YouTube, which is really great. So that's it for our agenda today. And I can never remember if I take a motion to adjourn. I'm guessing that we don't necessarily.
Make it, make it.
Thank you. Thank
I
you.
second.
And seconded by Miranda. Thank you. All in favor, say aye.
Aye.
Any opposed? All right, the motion carries. We are adjourned. Thank you, everyone. Appreciate it. Bye.